So one of the things that as we begin to talk about issues with gluten is that we'll be getting into a little bit of acronym mania and alphabet soup. And so I'll be using terms, repeatedly talking about TTG, IgA, and DGP, IgG, and EMA, IgA, and the interrelationship with AGA, and it can get a little, sometimes I misspeak because I'm just moving too fast with it. So if there's questions that come up, one of the things we have, you'll see a slide that lists the acronyms and goes through them, and we'll try to break it down. I was thinking about this just before the talk, and when we started this series in 2009, we did not have a talk on gluten at all. And we've kind of increased it over time, and now with the webinar that I did and this talk, we've got about 2.5 hours of talking just about gluten and its interrelationship. And there's still going to be issues and questions that come up, and we don't know all the answers. So we're trying to give you, some simple guidelines and ways to be able to work through the process on that. And people are coming in, but so you won't be graded on this, but just to help me understand, how many people had a chance to see the pre-webinar that I did? So, okay, maybe a third. Okay, so I'll keep that in mind. I'm gonna highlight a couple of those issues in the conversation here, but I'm not going to be diving deep into the pathophysiology. That is on that webinar. I really want to talk about the prevalence and the clinical application of what's going on. So our performance objectives are, we're going to talk about the prevalence and the immunoreactivity of gluten. We're going to talk about the diagnostic criteria. Mostly going to be talking about the diagnostic criteria as it relates to celiac disease, as well as wheat allergies, other kinds of non-celiac gluten sensitivities, and non-celiac wheat sensitivities. And they're not the same. This was a piece for me that remained a little bit confusing. I thought they were two different terms talking about the same thing, but they're not. Because as we'll see, 40% of wheat is glutenins, 40% of wheat is gliadins, and 20% are other proteins that can also have immunogenic effects, that can be epitopes, that can be reacted to as well. So here's the list of abbreviations, and the ones that I want you to pay attention to are the top 3. So I'm going to talk about TTG. I'm going to talk about it a fair amount, tissue transglutaminase. I'm going to talk about the newer test that we have available that I think about in parallel with TTG, and that's deamidated gliadin protein. So this is the current manifestation of the anti-gliadin antibody. I'll talk about that a little bit, but really this is a much more sensitive and specific test. And of note, I'll be talking about the IgG version of that. I'll be talking about both of them, but that's really where the juice is in the IgG of the DGP. That is the immunoglobulin G of the deamidated gliadin protein. And then when either of those are positive, we will be recommending a reflex test to the immunofluorescent antibody, the IFA, of an endomysial antibody, EMA, of the immunoglobulin A, IgA. So I'll say, well, we want to get an IFA of the EMA, IgA. And I'm being a little facetious about it, but I want to step through the process and give you the very specifics about what you'll do and how to do that. So, as we see, we're deepening our understanding in looking at gluten and gluten-related disorders. And when we think about that, again, we're not just thinking about gluten. In this slide, gluten is on the bottom, and we'll be looking at, gluten can have effects. We'll look at Dr. Alessio Fasano's work on gluten and its impact on changing intestinal permeability, on upregulating IELs, intraepithelial lymphocytes. We'll talk about its expression on toll-like receptors. We'll look at those effects of gluten on the body, but we also want to recognize that within wheat, there are other aspects. So we may actually see that there are FODMAPs, which are fermentable oligodimonosaccharides and polyols, which can have an effect on bloating, on other symptoms, on IBS, and there's some good research on using a low FODMAPs diet in IBS, and particularly in patients who have small intestinal bacterial overgrowth. But the fructans, there are agents within wheat that are FODMAPs. So one of the questions that's come up in the research is that when they're doing a double-blind randomized crossover trial using non-gluten materials versus gluten materials and comparing the two of them, and they don't see an effect, is it because of a FODMAP effect of the non-gluten but FODMAP positive material? So that's a consideration, and yet we'll also see that FODMAPs from wheat only constitute about 5% of the overall FODMAPs in our diet. So it's not a major source of it. So maybe that's not a real issue. But it's a question, and one that we need to consider, and will be in our consideration of food sensitivities. Actually, I should say food intolerances that arise from wheat itself. There can be allergies to wheat germ agglutinin, true IgE-mediated allergies that we want to consider. And then I spend a fair amount of time in the webinar talking about amylase trypsin inhibitors, which are proteins that are there, a class of proteins that do not allow for the appropriate breakdown of wheat into small enough polypeptides that they can be absorbed and broken down. So it prevents that from happening, and so we have antigenic epitopes that are 8 to 11 amino acids long that are actually causing problems. So the whole amylase tryptase inhibitor piece, from my perspective, is probably one of the major players in non-celiac wheat sensitivity. And I say that because it's not a gluten issue, it's another protein that's present in wheat. And that's where we begin to differentiate and dissect. So I do invite you to go back and listen to the course, the webinar that's there. It's probably something that you're going to want to listen to a couple times because it's pretty dense with information. So I've talked a little bit about the confusion of the terms, and I think in particular differentiating the non-celiac gluten sensitivity, which is an older term that was brought forth in the peer-reviewed literature really strongly in 2011. When we began to see our GI colleagues saying this is a real thing. In clinical practice, we'd been seeing this for 20 years where patients would come in and say they're sensitive to wheat, and we would take them off of wheat and gluten, and they would do better symptomatically. And in our practices, we were saying, gosh, there's something like 10 or 20% of patients who seem to be having this problem and they don't have celiac disease. That's been actually validated, and we'll look at a few studies that talk about the prevalence of that. But the non-celiac gluten sensitivity, non-celiac wheat sensitivity, probably on the order of about 15% of our patients, 10 to 15% of our patients. The intolerance side of things, which is going to be more FODMAP related, is probably a lower percentage. We don't have an exact number on that. Celiac disease constitutes about 1% of our patients in the United States, as well as we see the similar numbers in Europe. And then wheat allergy, that's a number that's probably around 0.4, 0.5%. So 25% of all Americans are following a gluten-free diet, which I think is a good thing. However, I see many people substituting tapioca flours and other kinds of agents that aren't necessarily good things and that may have additives in their non-gluten-free processed foods that I think we'll be talking about 5 and 10 years from now saying, these aren't good foods either, right? So one memory I have about 3 years ago is I walked into a market and I turned right and I walked into the fruit and vegetable section and there was a big sign over the top and it said gluten-free. And I loved it because it's like, eat whole foods. That's the way in which we want to be, dealing with gluten-related issues. But it's not what's happening, much of the time. So we see that the diagnosis of celiac disease has been going up and up and up since 1980, really kind of around 1990. I know for myself, I remember the first patient I saw with celiac disease, and it was in 1992, and it was an American, a white person. I was working with the Eskimo people on the Bering Sea in Alaska, and it was the husband of one of the other doctors, and that was the first patient I saw. So I remember that vividly, thinking, gosh, this is pretty rare. It only happens, was remembering from medical school, like 1 in 1,000. But now we're seeing that it's doubling, and it's been doubling every 15 years for at least the past 30 years, where 30 years ago, actually it's now 40 years ago, I've been talking about this long enough, 40 years ago that the prevalence was about 0.25%. Then it was about 0.5% in the late 80s, early 90s, and now it's at 1%, and it's been there. We haven't seen any recent new prevalence data around that. Is one of the issues that comes in when we look at the overall presence is that still about 85% of people who have celiac disease are undiagnosed or misdiagnosed. Now, when we started talking about this 10 years ago, that number was 93% of people who had celiac disease were undiagnosed. We're doing better, but still, the vast majority of people who have this as an issue are undiagnosed. And it's important to differentiate between celiac disease and non-celiac wheat sensitivity, because as an autoimmune disease, it's going to be a setup for many other, or at least an indicator, a marker, that this person may have other kinds of intestinal permeability issues that can lead to other autoimmune diseases. So when I have a patient with celiac disease, I'm checking them for other autoimmune diseases as part of the process. So here we see the data of a doubling every 15 years. This is true in the United States. Data from Finland says doubling every 20 years, again with about a 1% prevalence rate. Those people who are of Northern European descent tend to have a higher risk of it because they've got a higher genetic predisposition that's going on with HLA, DQ2, and DQ8, and I'll speak to that a little bit. The wondering was, well, is this just because we have better diagnostic tools? Because before we were just looking at an anti-gliadin antibody. Then we began to have the TTG testing, tissue transglutaminase, and we're measuring against the immunoglobulin A, the IgA. What Mayo did was they had blood bank samples back to 1973, and they went back and they looked in those samples, and that's where we get that 0.25% prevalence rate of a positive TTG antibody. Then they had other samples that were 15 years later, and it doubled, and other samples 15 years after that, and it doubled. So we see that the TTG positivity prevalence is going up. So it wasn't just that we were better at finding celiac disease, there was more of it that was going around, and that's what we're living in. So we see within this piece from the CDC and from the World Gastroenterology Association that there have been huge increases in the number of patients who are now diagnosed with celiac disease. And just out of curiosity, I'll say, how many of you know someone, a patient or a family member with celiac disease? And that is about 90% of the room. So it's amazing to me what we've been seeing just in our short lifetime. Now, because we've seen these changes, our genes haven't changed during that period of time. The genetic prevalence of HLA, DQ2, and DQ8 across a broad population in the United States is about 30%. In people of Northern European descent, Celtic descent, that number is closer to 45 or 50% in looking at the HLA, DQ2, and DQ8. But I want to highlight that of the 30% of people who have the genetic predisposition, only 3% of that cohort ends up developing celiac disease. So just because you have the genetic predisposition doesn't actually mean anything. Now, we'll find that there are a few use cases where evaluating that information is helpful, and we'll go through those examples. In addition to having manifestations of gluten, of celiac disease, there are other diseases. There is a gluten ataxia causing a peripheral neuropathy. People are having difficulty walking due to a peripheral neuropathy that is mediated through tissue transglutaminase 6, TTG6. A little bit different than the TTG2 that is the common test that we have done, but we can see that gluten can have other manifestations besides celiac disease. There's also another autoimmune skin condition called dermatitis herpetiformis. That is a gluten-mediated autoimmune skin condition that happens. Much, much lower prevalence, as we see only about 3 per 100,000. But that is increasing as well over the past 40 years. Others to consider. So the prevalence of non-celiac gluten sensitivity, it begs the question, are we just more conscious of what's going on? Now, I believe that we've been seeing this problem because I've been seeing it clinically for at least 20 years, but there does seem to be some changes that have gone on. From the time, let's say I was in medical school nearly 40 years ago, and now, a University of Maryland study said it's 6% of the population. Even when I listen to my GI colleagues like Dr. Bill Shea from University of Michigan or Dr. Fasano, who's at Harvard, they're talking about rates that are more like between 10 and 20%, which is consistent with what I have seen in my clinical practice, and I think that it's somewhere in that range. But I spoke about in the pre-webinar, like, why is that? What's going on? What are the issues? There's lots of theories about why that's happening, and I'll touch on a couple of them in a few minutes. But by and large, it appears to be a dose-dependent phenomena. We're eating more wheat than we did before. The wheats that we have higher gluten contents than they did before. And so that seems to be one of the major actors. The other major actor appears to be the changes in our gut microbiome that have lost diversity over the past 100 years, and that is part of the issue. So from my own personal clinical perspective and having read and talked to the thought leaders, I think those are the two major players in what we're seeing with that increase. With that increase. And then, of course, on the prevalence side, I mentioned there is a true IgE-mediated wheat allergy that is kind of most classically seen in baker's asthma. Bakers who are exposed to the aerosolized wheat in the air can develop an asthma that is a hyperreactivity response. There's also a IgE-mediated skin condition that can develop as well. So why the changes? Is it because we've had a change in our immune systems and they're not responding the same? Well, it's only kind of a partial explanation because we're seeing an increase in celiac disease in places that still have a high amount of infectious disease going on, where the immune system is going to be stimulated at an early age that goes on. There's been wonderings about, is it due to early introduction of gluten? But the studies actually show that introduction of gluten at between the ages of 6 and 9 months of age appears to have the lowest prevalence of developing celiac disease and wheat sensitivity. So you actually need to introduce it to the immune system at a certain period of time. Is it because of less breastfeeding, which probably is related to alterations and changes in the microbiome? There is an increase in the overall consumption of wheat. The amounts of wheat that we're taking in and the amounts of gluten that we're taking in are significantly higher. There's some people who have said, well, maybe it's because of the hybridization of the wheat and we have a change in the proteins that are there. But studies have been done, as I talk about in the webinar, that have compared ancient forms of wheat versus more modern hybridized forms of wheat. And there's actually more antigenic epitopes in the ancient wheat. And there's no significant difference in the immunologic reactivity between the two. So it does not appear to be that. There is good data on people who have had some form, some form of infectious gastroenteritis, and exposure to infectious gastroenteritis does increase the prevalence of celiac disease and does increase the prevalence of non-celiac wheat sensitivity. Again, I believe that that's all mediated through the microbiome and why that's happening. So, as we look at early life infections, there does seem to be a small difference and increase in there as a trigger. We also see infectious gastroenteritis as a trigger for adults. Again, probably microbiome mediated. I think that the microbiome is the biggest issue. Now, there's theories that because glyphosate is used at the time right before harvesting of the wheat, that may be an additional factor that's going on. There's studies that are being done about it. I'd like to think, yeah, that's the problem and it's all going to go away. But there are areas that do not have glyphosate where the people are continuing to have problems, same prevalence of celiac disease and non-celiac wheat sensitivity. And the increase that we've seen going on predates the use of glyphosate. So it may be an issue. We don't have enough data to be able to say that. I believe that removing glyphosate will help, but it's not going to eliminate the problem at all. And then there's the question that has to do with just the overall issues of permeability. Recall that I said earlier, and Dr. Mullen said, that when we have an autoimmune disease, we're going to have an increase in intestinal permeability. And we have increasing stressors. So we've got, there are many different factors, as we saw, that are going to have an impact on permeability. And is that one of the underlying drivers? So those are some considerations. I mentioned that 40% of wheat is glutens. 40% of wheat are the gliadins. And then there's albumins and there's globulins. But we find a high number, at least 50 different epitopes, due to those proteins not being adequately broken down. So the most immunogenic one, the 33-mer gliadin fragment, is not, it's the most immunogenic piece, but when we do anti-gliadin testing, this is not what we're measuring. We're not actually looking at this one specifically. We'll see near the end there's some experimental testing that does look at these kinds of specific antigens to see, are you having a reactivity to those immunogenic peptides? And we see that those peptides are resistant to breakdown. So one of the things about gluten in and of itself is it tends to be relatively resistant to digestive breaking down. So generally, epitopes are going to generally polypeptides are only going to have 3 or 4 fragments. But with wheat and with gluten, it's not broken down very well, and so we end up having larger segments, which will be immunologically reactive. So they're going to be antigenic epitopes. As I said earlier, the most common one is the 33-mer protein that's present there. So as we have all of these different epitopes, the body is reacting to them. Is our testing actually looking at those? No, it's not looking at those. It's looking downstream to say what's happening with damage that is caused after the antigen presentation to the T cell. So in that process, we learned that no one's really good at digesting gluten very well. That's because of the types of proteins that are present in gluten called prolamins. Prolamins have large amounts of sequences that are proline, glutamine, proline, glutamine, proline, glutamine. And so there are segments that are that, and the enzyme that comes, which is a transglutaminase, it's cutting at the glutamine in order to be able to do its job. But what happens is this sequence, this proline-glutamine sequence that's repeated, makes it very difficult for gluten to be broken down and digested properly. And we find that proline-glutamine sequence is where the tissue transglutaminase comes in, and it's meant to try to do its work. Now, we can see, let me come back here, at the bottom, we can see Is this working? Yeah, we go. We can see that whether or not we're looking at wheat or barley or rye or oats, all of them have various kinds of prolamins that are causing problems. There are all various glutens, types of gluten that are there. And that's why it's not just a wheat problem, but it extends beyond that, that these other places are having, these other grains are also difficult for us to be able to effectively digest. So when we have the protein and there are gliadins and glutenins and they're broken down by the transglutaminase, and the transglutaminase then leads to the development of a deamidated gliadin protein. And so that deamidated gliadin protein is something that we can also measure. These are going to be our two best measurement tools to be able to look at and understand celiac disease from a diagnostic perspective. So even if we don't have the genetic predisposition, we're not digesting gluten very well. And what we'll find is in those patients who have non-celiac gluten sensitivity, non-celiac wheat sensitivity, they are not only from that pool of people who get celiac disease, right? In celiac disease, we have 30% of the population who has the genetic predisposition, and everybody, I'll say everybody, it's a slight overstatement because it's only about 98 or 99% of the people who get celiac disease have the genetic predisposition. With non-celiac wheat sensitivity, non-celiac gluten sensitivity, that's not the case. While there's a slight increase in the prevalence of non-celiac wheat and non-celiac gluten sensitivity in patients who are HLA positive, who have the HLA predisposition, it's only a slight increase. The vast majority of people who have gluten sensitivity and wheat sensitivity issues are HLA negative. They do not have HLA DQ2 or DQ8. So there's an overall issue that goes on. So one of our friends and colleagues, winner of a Linus Pauling Award winner for his work, as Jerry talked about in relationship to intestinal permeability and the discovery of zonulin, which is a fantastic story to hear of a scientist who's just curious and found it because he didn't find what he was looking for, and he didn't have the results that he had when he was developing a vaccine to cholera because it continued to have problems, but he kept looking. And he said, oh, there's this other protein that we learned about. And so I've had the privilege of knowing Alessio now for 18 years, and I've watched his own learning grow and change, where he's now convinced that, the way in which the body relates to gluten is the way in which it relates to different bacteria. There's an immunologic reactivity that goes on. And so we see that immune response that's there to gluten. And that response happens for everybody. Not just in the people who have symptoms that related to gluten, but it happens to everybody. Then the issue becomes, well, if you're healthy and your immune system is in balance and you don't have permeability issues going on and you've got a normal microbiome, then you're not likely to have a reaction to gluten. And so part of his mission is to say, gluten is not the enemy. Gluten is an example of a symptom that manifests symptoms when we're out of balance. Now, he says that it's in the genetically susceptible patients, but the data says it's not just in those patients. It's in those patients, recall that we talked in the first lecture about the gene-environment interaction. And it's phenotypically, who's got imbalances, who's not healthy, who's got permeability issues, who's got alterations in their gut microbiome, who's got alterations in their immune functioning. Those are the patients who are susceptible to gluten. And so that's what we're going to see. And, here he says, if the person is healthy and they have got a good microbiome, if their barrier's intact, and, if their immune system is working well, and then they're not going to likely get triggered by gluten. So the goal is, it's not about avoiding or stopping gluten for everyone, everywhere, all the time, but rather recognizing that at least the patients who come to see me, They don't meet these criteria. So that's why when they come to see me, I'm going to remove gluten from their diet right away, if they haven't already. And if they've removed it 80%, I'm going to make sure that they remove it 100%. And I'm going to use that as part of an overall strategy that I'm taking with every single patient that comes to see me because they don't meet these criteria. So none of us are actually fully able to digest gluten in the best way possible. What we want to do is we want to have an immune system that's not hyper-reactive to what's going on. Okay, so now if you could get out your app, and we're going to do a little your smartphone or do it on your computer, and go to the Q&A and polling aspect. My first question that I have is, what percentage of your patients think they have some reaction to gluten or wheat? Type in a number. What percentage do you think is having a reaction to gluten or wheat? And we'll see what percentages line up here. People are saying it's not working. It's working for some people, for sure. Dan, does this aggregate, or is it just going to give it to me this way? Okay, I thought it aggregated, but what we're seeing is the numbers that are ranging sort of, actually I've seen from 7% to 85%. In my practice, I'd say it's probably about 2/3 of the patients think they have some reactivity to gluten that's going on. That would be the number that I would use. So we see there's a wide range. But it depends upon, if I'm in a primary care practice where I'm not seeing patients with a whole series of complex chronic diseases, that number is probably going to be lower. But in a practice like mine, where all of my patients have kind of multiple complex chronic diseases, that number is very high. And for me, I'm relating to it as, I'm going to assume it's 100%. I'm going to take them off of gluten, and then I'm going to reintroduce it and see how they do. And what I'm finding over time is between half and 2/3 of them have some issue with gluten. But again, I have a very specialized subset of patients in my practice. Second question. Do you think that you have a significant ongoing adverse reaction to gluten or wheat? Interesting. We'll give just another moment. 60-40. And the last one is, if from what I've said so far, what do you think your reaction is? Is it a wheat allergy? Is it celiac disease? Is it non-celiac gluten sensitivity? Or is it some other kind of food intolerance, like FODMAPs, something of that nature? And here we see, just looking at the populations overall, there's sort of an equivalence. Most likely that wheat allergy is going to be present at about half of the incidence of celiac disease. Those of you who are in the audience who know you have celiac disease, and that's interesting, 3% within a population that's here as well as on our live stream. That would be higher than we would expect in the normal population. So let's move on from here. Now, what we've done is Deanna's worked and created a schema that to be able to look at. Let's talk about what's happening with immune-mediated versus non-immune-mediated problems. So from an immune perspective, we'll look at wheat allergy. That is a IgE-mediated response to wheat germ agglutinin. We can also see that there can be respiratory allergies like the Baker's asthma that I spoke about earlier. We can see, and we'll talk about celiac disease specifically, and we'll talk about the immune-mediated aspect of non-celiac gluten sensitivity. Now, that may be different than non-celiac wheat sensitivity or wheat intolerance that's going on, which may be mediated through other things like the the amylase trypsin inhibitors that are going on, as well as other kinds of FODMAPs related issues. So we'll kind of break it down in this way. So gluten-related disorders are going to be those things that we used to say was gluten intolerance. Now we're moving to really use the term of the other celiac-like agents like gluten ataxia or gluten-induced peripheral neuropathy, dermatitis herpetiformis, non-celiac gluten sensitivity, and celiac disease. Those are all gluten-related disorders because it's specifically to gluten. Again, differentiating it from wheat-related problems. And then there's celiac disease. We don't use sprue or celiac sprue anymore, but some people will still call it a gluten-sensitive enteropathy. But the best term to use is simply celiac disease. And we'll go through first talking about the IgE-mediated immune response. That is a true allergy. When we're looking at allergy, we're going to look at an IgE reactivity, and the best ways to do that are either through some kind of, the gold standard is going to be using a skin test, or to use a double-blind placebo-controlled food challenge. That's the gold standard to be able to do. It's fairly difficult to do that in a placebo-controlled way. So that's only done really in a research setting, but we can use a food elimination and then challenge as a very useful tool. And that's the primary tool that I'm going to be using, as well as looking at IgE testing. There are some issues with skin prick testing because we see a crossover that occurs, a cross-reactivity from respiratory antigens that can also cause issues. We also find patients who are on antihistamines or steroids, they're going to have false negative skin testing that's done. So we can do an IgE-mediated blood or an IgE blood test, an in vitro assay. But we do see a cross-reactivity with certain grass pollens that are respiratory allergens that will tend to cause a false positive test in this. And then there's also, on the skin prick testing, we also see false negatives because we have very dilute agents that are being used in the skin prick test itself. So there's no really great test to be able to see this. So the oral food challenge, and that is removing the food and then introducing it back, is going to be the best way to do that. But that doesn't tell you at that point in time, is it an IgE-mediated problem where we need to keep them away from gluten for the rest of their life, away from wheat, or that we can help to heal their permeability, heal the microbiome, heal their immune system, and you can introduce it again. We don't know that with an oral food challenge, and that's the issue. So in practice, I look at doing IgE testing to look for, is there an IgE wheat reactivity that's happening? I'll keep saying IgE because I want to differentiate that. I am not talking about IgG reactivity here. That is not an allergy, that is a food sensitivity. I'm only talking about IgE. So next in that immunologic sequence of immune-mediated gluten and wheat-related disorders, we're going to talk about, move on to talk about celiac disease itself. I'm going to spend some time, and let's see how I'm doing for time here. Okay. Here we see on the top, that is the 17% of patients who have celiac disease who've actually been diagnosed with it. In the yellow, we see the 83% of people who have not yet been diagnosed, who have celiac disease but are not diagnosed and are having symptoms that are going on. Note that when children are diagnosed with celiac disease, it's primarily due to gut-related symptoms. When adults are diagnosed with celiac disease, it is primarily related to neurologic-related symptoms. Fatigue, brain fog, depression, anxiety, mood issues that are going on, fibromyalgia. Those are the things that are more common diagnostic presentations in adults in that yellow area. And then we see all the people who are the remaining 27%, 27 to 29% of people who have the genetic predisposition of HLA, DQ2, and DQ8, but they do not have celiac disease at this point in time. So I've used this term. 83% of the patients are undiagnosed or misdiagnosed who actually have celiac disease. It's better than it was 10 years ago, but it's still a huge number. So, and I think I heard Jerry say this earlier, but anyone who comes in with irritable bowel syndrome, right? So it's a garbage can diagnosis, but it's 20% of the population. Anyone who comes in with that should have a celiac test done. Now, one of the other things, and I'm trying to look for data on this, and I'll continue to look and search for it, but I believe that if someone has had a celiac test that's more than 3 years old, that I should repeat it, because I don't know that they have not actually moved into a change that's gone on in that patient group who have the predisposition. So I've highlighted on several times that not only with celiac disease, but also with gluten sensitivity, that there seems to be something that's going on with the microbiome. There's alterations in the activation of the immune system, and we see that imbalance as well as acute infectious gastroenteritis will have an impact on the development of these gluten-related disorders, including celiac disease. So we do see from studies that have been done that there are changes not only in the microbiome, but also changes in the metabolome of what's going on metabolically. The metabolome is going to be that aspect of the circulation of all the different metabolites in our bloodstream. Interestingly enough, the majority of which come from the bacteria in our microbiome that we don't even know how to measure at this point in time. But we do see changes, and those changes will affect intestinal permeability, gut barrier function. They will affect regulatory T cell function, as well as epigenetic gene expression of what's going on in the intestinal cells that are there. So let's now talk about diagnosis and what we do. Remember, I said the three acronyms that I want you to remember are tissue transglutaminase, deaminated gliadin protein, and endomysial antibody. So these are the best ways to be able to screen. And what we'll find is that we use the TTG and the DGP to do an initial screen. If it's positive, if either one of them are positive, then we will do a follow-up test, a reflex test, using an immunofluorescent antibody to the endomycelial antibody. We'll look for that. That can be confirmative, although most of my GI colleagues will still say, well, we really should get a duodenal mucosal biopsy in order to be able to confirm, because if we're going to ask someone to be gluten-free for the remainder of their life, if we're going to tell them they have an autoimmune disease with an indication that they are at risk for other autoimmune diseases, we should probably have a biopsy in order to confirm that. There's, from my clinical perspective, I don't move in that way. If I have a TTG or DGP positive and the EMA positive, I'm taking them off of gluten at that point in time, and I'm calling that celiac disease. Now, one of the highlights is that when I'm going to test someone, it's only valid. Any of these tests, including the mucosal biopsy, are only valid if they're currently being exposed to gluten. If they're truly on a complete gluten-free diet, then I have to reintroduce gluten in order to be able to do this testing. This testing is worthless if they're not on gluten. This testing is also problematic in the small subset of patients, about 1 in 100, who are IgA deficient. Because I'm looking at the TTG IgA. If they're IgA deficient, it's going to show that it's low. It's not low because they don't have a problem. It's low because they don't make IgA. And we find that the people who have celiac disease are 5 times more likely to have IgA deficiency than people without celiac disease. So it's a real issue, and we'll talk about that in just a moment. Now, the workaround there is that the deamidated gliadin protein, the sensitivity and specificity is actually on the IgG. So when you're going to the lab, or like I work with LabCorp, and the panel is a IgA and IgG to tissue transglutaminase, and an IgA and an IgG to deamidated gliadin protein. So what I do is I look at the IgA for tissue transglutaminase, and I look at the IgG for deamidated gliadin protein. Those are the two things that I'm looking at that are going to help me to understand what's going on. As I said, it has to be during a gluten challenge, and so these are the two that I'm going to look at. I'm going to reflex with the endomycel antibody. But as I said, there's an increase in overall IgA deficiency, so what I do when I run a panel on this is I measure a total IgA. I want to make sure, because think about it, if the TTG IgA is negative and the DGP IgG is positive, I've got a pretty good sense that this might be celiac disease. But I need to run a reflex test in order to do that. But the reflex is to IgA. If they're IgA deficient, that test is going to turn up negative, and I'm not going to know what to do. So now I need to go and do a mucosal biopsy in order to figure that out. Is this tracking for people? I'm just kind of stepping you through the process to be able to do that. So here's the usefulness. Now, we used to focus more on anti-Gluten antibody, and I'll speak to that in just a moment because it still has utility. But our primary labs, Mayo, ARUP, LabCorp, Quest, are not running the anti-Gluten antibody anymore. They're only running the deamidated gliadin protein. And here we see the specificity of the deamidated gliadin IgG is at 98%. It really is the best single sensitive marker. When we look at serology results, this goes through various options, and the one I want you to pay attention to is the third line. So here we see the IgA is negative, and the total IgA is low, and the IgG, the TTG IgG, is positive. Note that the tissue transglutaminase IgG is not specific to celiac disease. There are multiple other autoimmune diseases that will show a tissue transglutaminase IgG to be positive. So you can't make that determination here. Now, we see that the anti-deamidated gliadin protein, the second to last column on the right, is positive. But this person has a low total IgA. So I'm concerned, I want to do that, but because of the low IgA, I can't go and run, I just said this earlier, but I can't go and run the reflex endomycel antibody. I need to do a mucosal biopsy. In this situation, it's an interesting one because I've had it happen a couple times to me, and one, the mucosal biopsy was positive. Great, you have celiac disease. One, the mucosal biopsy was negative. Now, the mucosal biopsies aren't correct all the time, and it depends upon the degree of antigen that you're exposed to. So, in that case, I took the person off of gluten and told them, I believe you have celiac disease. It's not confirmed, but I don't want to continue to drive a problem. But that's a clinical decision at that point in time. So, this is one where people will go ahead and they'll say, maybe I should measure the HLA DQ2 and DQ8. Because if you do have that, if you do have the genetic predisposition, then it is possible that you have celiac disease. But if you don't have the genetic predisposition, it is super highly unlikely, that's a medical term, super highly unlikely that you have celiac disease. So, in doing this kind of testing, it's widely available and it does correlate with villus atrophy, but we have some patients who have only partial villus atrophy. And that's why I said you may have someone who does not have positive biomarkers now, but 3 years later with more damage, they do have positive biomarkers. And that's why I repeat this testing, because we do see the incidence of it going up. Now, I've talked about looking at IgA deficient patients, and as I said, it is much more likely to be IgA deficient in a patient with celiac disease, and that's going to give you a false negative results. So what am I going to do if I have someone who's got a low total serum IgA? They're IgA deficient. Well, I can measure the DGP IgG. I've mentioned that already, and that's a pretty good marker. And if that's positive, then there's a couple of other things I can do. I can look at anti-gliadin antibody, but this is not available through the standard testing. It's available through some of the specialty labs that we have available because it is associated with an increase in overall all-cause mortality. Causes, we see that patients who have neurologic issues have increases in total AGA, anti-gliadin antibody. So that's a consideration. The other consideration, the one I move to more clearly, is I mentioned just a moment ago, is I do the HLA typing. I look for DQ2 and DQ8. Do they have the genetic predisposition? Because if I've got someone who's eating gluten, their DGP, IgG is positive, their total IgA is low. Now I'm going to check to say, do they have the genetic predisposition? And I'm sorry, there was something on there that do they have the genetic predisposition? If they do, then I will send them for a biopsy. If they do not, I will not send them for a biopsy, right? Because they don't have that. Now, if that patient's coming in and I've done all that and the HLA, DQ2, and DQ8 are normal and they don't have celiac disease, I'm still going to take that patient clinically off of gluten. Because I want to see, do they have a reactivity when I add it back? So I'm kind of highlighting now, I'm stepping away from, in that case, I've determined they don't have celiac disease, but they may still have non-celiac wheat sensitivity going on. I'm going to take them off of that. Another subset of patients that I would consider is someone who's been clearly and totally off of wheat and gluten for 3 months or longer period of time. And I say completely off of it because, I have patients who come in and they tell me they're gluten-free, and I'll say, gosh, I'm looking at your 5-day diet history here, and it says you had a hamburger yesterday. Yeah? Did you have a bun? Oh, yeah. I said, well, I thought you were gluten-free. It's like, well, I'm mostly gluten-free, which is kind of like being mostly not pregnant. So you're going to have to reintroduce gluten. Some patients don't want that. Some patients will say, no, I don't want to do that. In that subset where I'm concerned, let's say they have a family history or another autoimmune disease, I'm going to check the DQ2 and DQ8 just to say, do you have a predisposition for that? So I'm giving you a use case of another time where I'm going to be looking at the HLA, DQ2, and DQ8. And, as we see in the picture here, we have gluten and gliadin, and we go over this in the pre-conference webinar on the pathophysiology of it. It's coming across, and we see the negatively charged, gliadin peptides that are here, and they're connecting with the tissue transglutaminase, and that's going into the antigen-presenting cell. The antigen-presenting cell then takes that to the CD4 cell and says, is this a problem? Now, in those people who have the DQ2 and DQ8 predisposition, they're going to be predisposed to having a reactivity that goes on from that gliadin molecule, from that negatively charged gliadin molecule. So I've tried to highlight, when do I do the genetic testing? So if the baseline serology, I've looked at the DGP, IgG, and I've looked at the TTG, IgA, and they're both negative. Or if I have someone who's low IgA, then I'm going to consider getting the DQ2 and DQ8. If those are negative, they don't have celiac disease. I've kind of gone through this use case already. Now, if they are positive for the DQ2 and DQ8, let's say the patient of mine who's coming in who's been clearly off of gluten for 3 months or longer period of time, but I want to understand, do you have this going on? Then I will do the typing. And if the typing is positive, then I'll say, I would like to do a gluten challenge for you. And in a gluten challenge, I need to be giving at least 3 grams of gluten a day. After 2 weeks, if they're unable, and that this note right here should say if they are unable to continue, then I'll go ahead and recommend a biopsy. But I've done the gluten challenge. If they're able to continue on that, and they do it for a 6-week period of time, I've gone 4 weeks, I've gone 6 weeks. The standards from the American College of Gastroenterology are 6 weeks total, or actually they're 8 weeks total, 6 weeks additional period of time. Then I've got enough gluten in the system that I can measure a TTG and a DGP and see if they have any reactivity, and I can get an endomysial antibody. Right? Again, this is all presuming that they have a normal total IgA. So we've gone through a couple different use cases, and I want to summarize here that what I do in practice is I have a panel, and it's measuring total IgA, it's measuring the TTG, both IgA and IgG, it's measuring the DGP, both IgG and IgA. And I do it that way because it's hard to separate them in the ways in which I order through the laboratory. So if I had my choices, I would just get the DGP IgG and the TTG IgA, but I don't really have that choice. So I get this, and it reflexes that if either of those are positive, that they will run the endomysial antibody. But I am measuring the total IgA in the process. For me, clinically, that meets a diagnosis of celiac disease. Some of my other colleagues will then go ahead and confirm that with a small bowel biopsy. But as I said, I've had experience where the small bowel biopsy is negative, but I still consider those patients to have celiac disease. And then occasionally, in special use cases, I'm going to consider running the DQ2 and DQ8. But I'm highlighting that because I see people who have testing for the DQ2 and DQ8, and it says, I have a risk for celiac disease. And it's like, yeah, you have a risk of celiac disease, but you may be in the 97% of the population who has the risk but doesn't have the disease. And so if I've done the phenotypic testing and you don't have the disease, it doesn't really make a difference to me that you have the genetic predisposition. It's not useful information clinically except in very specific use cases. And then when we're looking at the role of gluten and gliadin beyond celiac disease, you can consider getting an anti-gliadin antibody. So the things that we've talked about, the Mayo Clinic guidelines pretty much follow exactly what I've just said here. We have a little more emphasis on the DGP than their guidelines do. And what they'll say is, if you've got someone who's got any kinds of symptoms going on, steatorrhea, abdominal pain, I say anyone with IBS, test for celiac disease. If we've got someone again, whose first-degree family member a relative has celiac disease. That's someone, even without symptoms, we're going to want to measure, and we use these simple tools. Now, what they also recommend is that if we have someone who has elevated LFTs that are unexplained, which I find quite often to be related to non-alcoholic fatty liver disease or to alcoholic hepatitis. But if they're elevated, that's a subset of patients that you also want to consider doing the testing on as well. So we see the recommendations that are here, and just to highlight a couple things is that if the suspicion is high, you should do a biopsy even if serologies are negative. Jerry, do you do that? Out of curiosity? No. And I don't either because, I have the suspicion, and if the suspicion is high and the serologies are negative and the IgA is normal, then I'm going to go ahead and I'm going to assume that they have a non-celiac wheat sensitivity. I'm going to take them off of gluten anyway. So it's not going to make a difference in terms of what I'm doing clinically. And then if they have exposure to gluten in the future and they have a worsening of symptoms, and it's 3 years or more later, I'm going to repeat the serologies to go on. And one other note is down at the bottom here is that the TTG is not a good test. The TTG-IgA is not a good test in kids who are less than 2 years old. But the DGP is a good test in kids under 2 years old. So, keep that in mind. That's why I run both of them at the same time. So we've talked about the immune-mediated problems of allergies and celiac disease. Now let's go on to talk about non-celiac gluten sensitivity. And Dan, there must be a problem with my clock because it says I don't have as much time as I thought I had. So, so I'm going to move through this so that we can talk about some cases. But I wanted to really highlight that. And up front, I'm going to highlight that when we're talking about non-celiac gluten sensitivity and non-celiac wheat sensitivity, there are no good tests. It's a clinical determination, primarily. We'll talk about where the data is, but just to kind of cut to the chase, because I've just spent a lot of time talking about diagnostic testing for celiac disease, there are no good tests for gluten sensitivity or wheat sensitivity. So this is kind of talked about as a no man's land, and a lot of patients, who have irritable bowel syndrome, they have some form of gluten sensitivity that's going on as well, but it's not celiac disease. So that's why I'm going to check for celiac disease, and then I'm going to use a gluten-free trial, a gluten-free diet. And when I take a gluten-free diet, I'm also making it a dairy-free diet, and I'm also restricting some other things because once people have taken gluten out of their diet and they're really going to do it, they're willing to take some other things out of their diet as well. And that allows me to have an opportunity to see, are there any other kinds of food antigens that might be causing a problem? So my general gluten-free diet that I'm recommending to people is an elimination diet where I'm going to use a much lower number of antigens. So we see that there are differences between gluten sensitivity as well as versus celiac disease. And some of those differences are in the antibodies that I just talked about and the reactivity that goes on. But there's also differences that occur within the degree of permeability. Gluten sensitivity is not actually associated with significant changes in intestinal permeability, whereas in celiac disease it is. We can see extraintestinal symptoms that happen in both celiac disease and in gluten-sensitive, non-celiac gluten sensitivity, although much more common to have other kinds of non-intestinal issues or extraintestinal issues with celiac disease. We see the role of intestinal symptoms are actually relatively similar between the two, of diarrhea and abdominal pain, gas. Sometimes we will see, because of the atrophy, the villus atrophy that happens in celiac disease, that at the end of the villi are disaccharidases that break down sugars. So when the villi are atrophied, there's no disaccharidases. The disaccharidases actually signal the pancreas with cholecystokinin to be able to release pancreatic elastase. So it is common that we will see maldigestion due to low pancreatic elastase levels in celiac disease patients, and that's why we see smelly and fatty stools, because of the cholecystokinin. It's also not only stimulating the pancreas, it's also stimulating the gallbladder to release the bile. So this is why we see that difference. Now, I noted earlier that we have a decreased barrier function with celiac disease, but we see an increased barrier function with gluten sensitivity. This is a bit paradoxical, but it is a difference between the two that are going on. And you can say, wait a minute, didn't you tell me that gluten causes problems with permeability all the time? And it can cause changes in permeability, but it is not associated. Think about permeability as, I believe you heard Jerry say, not as an on-off switch, but as a slider, as a dimmer switch. It's an off and on kind of phenomena. And so when we're looking at at our patients who have IBS, who have been diagnosed with non-celiac gluten sensitivity, some of them are going to have characteristics that look more like celiac disease, and some of them are going to have symptoms that look more like food sensitivities that are going on. So when we say patients who have non-celiac gluten sensitivity and a lot of different food sensitivities as well, I'm reactive to this and this and this, they may actually be having food allergies that are going on. So it's something that we want to consider in the whole thing. We see that this symptom complex of IBS with non-celiac gluten sensitivity, there's a low-grade inflammation due to alterations in the microbiome that are going on. And that low-grade inflammation that's happening in the gut will have an impact on changing the permeability, not only in the intestine, but also in the blood-brain barrier. And so we can see some other changes that go on, and thus the relationship of non-celiac gluten sensitivity with dementia. If you're familiar with Dr. Dale Bredesen's work on reversing Alzheimer's disease, one of the things that he talks about is about taking those patients who are having mild cognitive decline or mild cognitive impairment going on, a MoCA score of 22 to 26, and taking them off of gluten. In fact, even in patients who have Alzheimer's disease, who have true dementia and changes in activities of daily living, taking them off of gluten may be a useful consideration to do. So while both non-celiac gluten sensitivity and celiac disease are immune-mediated, the immune activity in non-celiac gluten sensitivity is in the innate immune system rather than in the adaptive immune system. So in the adaptive immune system, which is going to be the antigen-specific immune response, whether a T cell or B cell or macrophage-mediated activity, whereas the innate immune system are going to be the production of those inflammatory cytokines that I talked about in the lecture earlier this morning. So the quick summary of the difference is in celiac disease, it's an autoimmune process, which means they're at increased risk for developing other autoimmune diseases. They're having villus changes, intestinal changes, they're having changes in the signaling to the pancreas and the gallbladder that's going on, they're having malabsorption that occurs, and they are HLA-DQ2 or DQ8 positive. This slide says 100% of the patients. Data is between 98 and 99% of the patients who have that, as well as the risk of other autoimmune problems. Whereas with non-celiac gluten sensitivity, they're going to have normal mucosa. There's going to be an increase in their intraepithelial lymphocytes, but they don't have malabsorption. They have a little bit of increase in the HLA, DQ2, and DQ8, but it's not everybody that's going on there. And there's not systemic inflammation. Now, this may beg the question, so why do you care? If it doesn't cause any of those problems, it doesn't cause malabsorption, it's not an inflammatory problem that's going on, we don't see a major immune reactivity that's going on, and yet these patients, they don't feel good. They have bloating, they have diarrhea, they have abdominal pain, they have oftentimes irritable bowel syndrome-like symptoms that are going on. And so what we see is that there is some activation of the innate immune system. We don't know what the long-term consequences are of that. And we do see, as Dr. Fasano said, that gluten acts like an infectious agent, and it's going to stimulate an immunologic reactivity to it. So for us, that's what makes sense. Now, I've said right at the beginning of this is that when we look at other biomarkers, we don't see significant differences. We do in celiac disease, we do in wheat allergy, but we don't see that in non-celiac gluten sensitivity. And so in order to do this, we really are looking at, well, what's the clinical reaction when I put them on a gluten-free diet and then I'm reintroducing that? What's going on? And when I'm using a gluten-free diet of any kind, I'm having the person be on that for at least 3, preferably 4 weeks period of time. As we learned at AFMCP, the IgG presence will decrease. It's got a half-life of 23 days. So I'm going to have at least a 50% reduction in my overall immunologic reactivity if someone is reacting to gluten. And that's why I look at that 3 to 4 week time frame before I reintroduce what's going on. Now, some studies that have been done that have looked at anti-gluten antibody and have said that, 50%, there's a 50% increase in the number of patients who have non-celiac gluten sensitivity who have elevations in their anti-gluten antibody. 50%. But the issue here is that there are other reasons for the AGA to go up, and there are a number of people who have non-celiac gluten sensitivity who have normal AGAs. So overall, it's not a good screening test. It's a clue, it's a pointer to what may be going on. And when I have someone who is refusing to do a gluten-free diet, I may run an anti-gluten antibody in hopes that I find that it's positive as a justification to be able to take them off of gluten. But that's a reach. And generally, because of my view and my statements to patients, they're doing that clinically without me having to do that additional testing. So we see in the left-hand column for gluten sensitivity, that the EMA is negative. The TTG is negative. The DGP, not here, is negative. The anti-gluten antibody is going to be positive about half the time, but that means it's going to be negative half the time, and so that's a coin toss to me. So that's not really a very good screening test to be able to do. And as we see, the genetic predisposition is slightly increased, but it's not a complete penetrance, so doing that test doesn't really help me either. So again, no perfect test for gluten sensitivity. The gold standard is going to be the elimination diet and what we have to do. So it's distinct, it's different. I'm going to move through this quickly because I want to talk about a couple cases. It's going to have some increase in the innate immune system, in cytokine production that are going to be related to this, and that the other testing that we do for celiac disease is not helpful in the setting of non-celiac gluten sensitivity. A lot of patients feel like they have some issue going on, and as I said in my first talk, you want to be listening to those patients and you want to give them a trial. But then when you're adding back the foods, you're looking at, well, what are the symptoms that you have going on? Someone asked me after the first talk, is it possible that when you're reintroducing food that the symptoms they have are silent and you're really causing a problem? And yes, that is a problem. That is a consideration. But from a clinical standpoint, what I'm doing is, if I've got someone who's presenting to me with problems of skin issues, then I'm going to say, I want you to pay specific attention to what's happening to your skin when you reintroduce gluten. If they've got mood-related issues, I want you to pay specific attention to what's happening with your mood. If they got gut issues, so I'm having them point to where, if you will, their Achilles heel is, their imbalance is. And so when they're adding back gluten, and when you're adding back gluten, you don't want to be adding back a little portion of it. You want to be getting a good dose of it over a day's period of time and use 2 days to see, do I have any reactivity that's going on in relationship to it. Now, I talk a little bit just about non-celiac wheat sensitivity because there are other components besides the gluten. Remember, we look at 40% are gliadins, 40% are glutenins, 10% are globulins, and 10% are albumins that are going on there. So there are other proteins that are present that we may be reactive to. This is true within the presence of not just the proteins, but also the carbohydrates that are present, the mono and disaccharides and polyols that there may be some reactivity to. So when we look at the data on FODMAPs, non-celiac gluten sensitivity, there have been some studies that have been looked at. Where's my study that I was supposed to see here? Okay, I thought I had a graphic here of Bizikarsky's study. But when Bizikarsky did this study and they looked at, comparing these two groups of people, who were randomized on a high gluten, low gluten, or a placebo whey protein diet, and what we saw was on the low gluten and high gluten, even though they both have wheat, they both had problems. They both had reactivity. So this was thought to say this must be a FODMAP-related issue, but the issues with the study itself, which said this is really a FODMAPs problem, had more to do with the way in which the study was designed. And so non-celiac gluten sensitivity, non-celiac wheat sensitivity does not primarily appear to be a FODMAP issue. There are some small subset of patients where that may be the issue, but it's one that in the realm of prioritization, I want to say much less of an issue to be concerned about. More of an issue and more of a consideration is to look at, well, what are the other kinds of proteins that may be causing problems? And so we can see that there's gluten as one of the principal proteins that people are going to be responding to. And then what are the issue with FODMAPs, where we will tend to see some changes in gas production and bloating. But for me, the bigger issue is in relationship to these amylase trypsin inhibitors. The amylase trypsin inhibitors, which are blocking the digestion of wheat from happening normally. And this is happening not in the gluten and gliadin portion of the wheat, but in the other, in the globulin portions of the wheat that are going on. And there's some questions also, as is talked about by Volta and all, in terms of dietary triggers. And Dr. Volta is one of the preeminent doctors writing about non-celiac gluten and non-celiac wheat sensitivities, in terms of the other issues that may be occurring with it. And so we can see that in addition to these things, there's also an increase in immune activation that is related to another protein called the CD14 protein. And we look at non-celiac wheat sensitivity, when we expose patients to wheat, what we see is that versus placebo, that there's an increase in overall symptoms, an increase in bloating, an increase in abdominal pain, an increase or worsening of stool consistency. This is the data that's very similar. This is from Antonio Carraccio in Italy, but very similar to the Bizikursky data out of Australia and Monash University that is highlighting the overall concerns that were going on. And we'll move through this. But what we find is that there is clearly a wheat sensitivity issue that is separate from a gluten sensitivity issue that's going on. Now, we can talk about that as food allergy, but really there's a difference between wheat allergy, non-celiac wheat sensitivity, and celiac disease, as we highlight here in this. If you have a true allergic reaction, it's going to happen in minutes to hours, whereas the non-celiac wheat sensitivity problem is happening over the course of days. It's involving the innate immune system, and we are not yet sure if there are any long-term complications. In talking about laboratory testing, to be able to specialize laboratory testing to look at non-celiac gluten sensitivity and non-celiac wheat sensitivity, there are some other antibodies that are being evaluated. Recall that I talked about the 33-mer gliadin protein before. There are other glutamorphins, gliadomorphins, agglutinins, where there's experimental testing that's now looking at all of these different kinds of things. I think that it's fascinating to look at. If I have a patient where I'm not really clear on what's going on, I will do this kind of testing occasionally. It often comes to me as well. So we see, actually this slide I thought I had asked to be hidden, because there's been people who have asked about, well, can you measure anti-gliadin antibody in stool? And it's a really interesting idea. There's one or two labs out there who are doing it. You think, well, if there's going to be a problem of an increase in anti-gliadin antibodies, wouldn't it happen in the stool before it happened in the serum? And the theory is great, but there's just no peer-reviewed literature that has evaluated that to be able to say, is this really the case? The one study that's been done says it doesn't help to diagnose for celiac disease, and it's not really a very useful screening test. So older studies that have been done that said this looks promising, but we don't see any data really coming through. So in the few minutes that we have left, we're going to just talk about a couple of different case studies. So in the first one, we've got a 43-year-old woman who comes up with fatigue and brain fog, a low-grade fever, joint pain, has had the symptoms for about a year. There's no clear trigger in the evaluation of it. She has a history of Hashimoto's thyroiditis, and her father has an autoimmune disease. Did a workup where the metabolic profile and CBC were normal, the ANA was negative, the rheumatoid factor was negative, the SED rate was negative, all of them were normal, and she's got a TTG IgA that's positive, a total IgA that's normal, and an elevated HSCRP at 2.3. So Dan, is that enough to diagnose celiac disease?
Well, you switched it over. I was going to ask you the questions.
Yeah, I know.
So what do you think? Is that enough to diagnose celiac disease?
What I would want is I would want to also see a reflex test of the IgA to the endomysial antibody as a confirmatory test to be able to do that. That's generally where the standards are to be able to do that. So I would say this is presumptive at this point in time, but I would at least at minimum want a reflex test to the EMA to confirm that, which I can do because her total IgA is normal.
Mm-hmm. And you have said that you don't necessarily get a small bowel biopsy for that.
I don't. And that's for the past 10 years, and I haven't done it in that way. And, there's some interesting data on that, but it's, I find it's more, most of the GI doctors will do a biopsy, and a lot of the primary care doctors won't do a biopsy.
That's generally what I do. And do you also do the anti-deaminated gliadin, IgG and IgA in that?
Well, in this case, it's already done and the TTG is positive, so it doesn't matter. Mm-hmm. If the DGP was positive or negative, I wouldn't change my recommendation at all. I would do the EMA.
Okay.
But I generally get that as part of my panel.
Right. And so when just and I've had a number of patients that just the anti-gliadin IgG is elevated. Is that enough? So I will say it's enough for me to tell them that they should be off of gluten. Is that enough for you, or do you have to have confirmatory serum markers?
So I'm going to tell them to go off the gluten whether the AGA is positive or negative. So from that standpoint, but if I have someone who presents to me and they have that, yes, I'll say, yeah, this is a good reason and justification. Now, as I said, and maybe you weren't listening, but as I said,
I was listening.
You were listening.
Yeah.
As I said, there are other factors that can cause the AGA to be elevated as well. So it's not a super sensitive and specific test.
But you were talking about the AGA or the deaminated?
Oh, I was talking about the AGA.
Yeah. So I was talking about the deaminated. So
I wasn't listening, and I wasn't listening.
So you weren't listening to me. Yeah. All right. Let's just clear.
So it's clear.
All right. Is that all clear? Did everybody get?
So you're saying if the DGP,
if the deaminated IgG is elevated, which I've seen a number of times without any other serum markers being elevated, is that enough for you to say?
No, I would want to get the EMA spelled incorrectly there, but yes, the endomysial antibody.
Right.
I'd want to get that as a reflex test.
And if that's
provided that they have a sufficient total IgA. Right? If they don't, then I can't do that test. Then I got to send them for a biopsy.
Okay. All right. So we've kind of talked about your flow chart process, and then the last question here is, how do you frame that for a patient in terms of their autoimmune presentation and the trajectory? What do you say to them?
One of the things I say is that the number one risk factor for having another autoimmune disease is having an autoimmune disease. And now you have celiac disease, or we've diagnosed that. So I'm concerned about problems in the future that are related to that. Hashimoto's thyroiditis, other kind of, rheumatic diseases. I say, but we know that there are common factors in all of those, and they relate to intestinal permeability, and they relate to your microbiome, and they relate to your immune system. So what we want to do is we want to focus on healing the lining of your gut. We want to bring your microbiome back into balance, and we want to make sure that there's no increase in inflammation. In this patient, we see her CRPs at 2.3. There's some inflammatory issue going on. Is that inflammatory issue just due to the celiac disease, or is there something else that's a driver? Whether it's part of those intrinsic risk factors, root causes, or whether it can be some other antigen or toxin or infection that may be influencing that. Let's go ahead and work on that to be able to determine that, because that's going to decrease your risk of developing other autoimmune diseases in the future.
Let's go on to the second case, and let's do the second case. I'll read this one.
Okay.
So this is a 45-year-old male, presents with a history of excessive flatulence, occasional diarrhea without blood, persistent angular stomatitis. He notes that these GI symptoms present after eating out on the weekends. During the week, when he preps his own meals, he doesn't report these symptoms. He has a normal BMI, history of weight loss of 15 pounds over the last 2 years, with no lifestyle changes. He has been diagnosed with IBS. There's a family history of celiac disease, and he's been trying gluten-free on his own, at least during the week. And his prior labs, CBC with a low normal, MCV, but normal iron, ferritin, TIBC, and folate levels. So in this case...
And did he have celiac testing done?
He has not had any celiac testing done. So then the question is, what do you do? What do you do with this guy?
Absolutely do a celiac panel on this gentleman. But the issue is he's been trying a gluten-free diet. Now, I've heard it said there is no try, there is do or do not. Some wise guy said that. But I see patients who, they say they're doing gluten-free, but they're really not. And then it becomes a value judgment of trying to figure out, well, how much gluten are they actually being exposed to? Can I run the test or not run the test? And that's an open question to be able to ask. Certainly with the degree of weight loss that he's had over that period of time and a family history, there's got to be an evaluation that goes on. But then the question is, do I need to challenge him, or is there enough there? So I'm actually, and I talk to the patients about how often do you have it, and we try to get real. And in terms of, I want them to be having some average, as we saw from the ACG or the American Gastroenterological Association guidelines, at least 3 grams of gluten a day. And if he's had that kind of exposure, then I'm going to just run the same panel that I did before. Mm-hmm. If he's not had that kind of exposure, then I'm going to run a DQ2 and DQ8 and see if he's got the genetic predisposition. If he does, then I'm going to recommend a gluten challenge. And I've had this happen, and I've had patients say, I'm not going to eat gluten. They're just not going to do it. And so then I just don't know the answer to that.
But then you do that DQ2 and DQ8, so you're doing that in those instances to kind of rule in or out, to a large extent, celiac disease, right?
Well, I'm just ruling out, is it possible or is it not possible?
Right.
Because if they got it, it's possible. If they don't got it, it's not possible.
Right. So if he's negative for DQ2, DQ8, then you can say...
Then I'm going to say, this looks like a concern, from the eating pattern where you're vigilant, but when you're not vigilant, you're having some symptoms, there may be some exposure. I'm going to recommend that you be on a gluten-free diet. Let's work with the nutritionist and help with that. And it may also say, and there are some protease enzymes that are helpful for small exposures to gluten that you may take when you go out to eat, because those have actually been demonstrated to be helpful for being able to decrease symptoms, as long as your gluten load is less than 2 grams.
Mm-hmm. Mm-hmm. So, and then the last question that we'll ask on this, and then we'll just skip that third case and take it in the Q&A. But okay. The last question is, so in first-degree relatives of a patient, I should say, if a patient has first-degree relatives with celiac disease, do you then order a DQ2, DQ8 on their family members to see if they are potentially at risk in that way for CD, as opposed to they can be obviously at risk for this many-headed hydra. You do not do that on a regular basis.
Not unless they're having some symptoms.
Mm-hmm. So if there's a mother, I've had situations where the mother has celiac disease, and then I have suggested that her children be tested for DQ2, DQ8 to know over time if they, over time, need to, every 5 years, perhaps get tested for a celiac panel.
That's an interesting approach. I mean, I think that it's valid. I just haven't done it that way.
Okay. All right. So we're gonna skip this third case. We'll probably come back to it in the Q&A, and you can move on to your close.
Okay. So where do you go with this? There's a lot of different pieces that are there. We've talked about food intolerance, which would be like the FODMAP related issue, and we'll go into that a little more. I think Liz is going to go into a little more talking about FODMAPs and its relationship with IBS. I've had an interesting journey with that in terms of clinically, because a low FODMAP diet also decreases the diversity of the microbiome, and I don't really like that. So, it's more of an indication of an imbalance rather than a long-term answer. So it's a diagnostically useful tool, but I don't think it's a long-term clinically useful tool. And then talking about food sensitivity, and we've talked about non-celiac gluten sensitivity, non-celiac wheat sensitivity, where the gold standard is going to be an elimination diet and then a re-challenge, usually at 4 weeks period of time. So we've gone through talking about understanding and parsing out the difference between wheat allergy, between celiac disease, between gluten and wheat sensitivity, as well as these FODMAP-related issues. We haven't spent a lot of time reviewing what am I going to do to evaluate for celiac disease. I'm going to get this kind of panel where I'm looking at DGP, deamidated gliadin protein. I'm going to look at TTG, tissue transglutaminase. I'm going to look at total IgA, and if either of those DGP or TTGs are positive, the TTG IgA or the DGP IgG, I told you I was going to throw lots of letters at you, then I'm going to get a reflex test to the EMA. If that's positive, then for me, I'm calling that celiac disease. I've had patients who I've said, I believe that's happening, and they want to get a biopsy to be able to confirm that. So those are the ways in which I approach it. I generally look at IgE-mediated serum testing for wheat when there's a concern about a wheat allergy. The concern has primarily come up for me, interestingly enough, in patients who work in bakeries, where that's where I'm particularly concerned about. I don't find the skin testing to be as helpful as I want it to be. Different than other forms of allergy testing, the skin testing is sort of notoriously not good enough for looking at wheat allergy. And then, for the non-celiac and non-celiac wheat and gluten sensitivity, that is going to be a diagnosis of exclusion, and it's going to be a clinical diagnosis that I'm making. And so I'm always looking at a therapeutic trial. We'll have some time in the Q&A to talk about food sensitivity testing. Personally, clinically, I'm not a big fan of food sensitivity testing. I don't use it very much at all in my practice and have not.